get going, and what I wanted to do here is just briefly go through where we stand today with the management of neuroendocrine tumors, what we call the epidemiology, so the number of new cases and things like that. And I think this would probably work best if you have questions. Just raise your hand. We can just pause the presentation and do the questions as we go along, because I don't necessarily have to get to the very end of the slide. So it's a number of slides, but these are mostly sort of just to jog my memory to sort of remind me what I was going to talk about. So these are my disclosures. So I do receive some research support from a number of companies and consult for others. And these are my objectives. So I wanted just briefly to talk about how common NETs are and why we do need the better treatment and why we need medical oncologists, why this is not a disease that can be surgically removed for a lot of patients. And then maybe briefly talk about how we sort of what we call sequence therapy, how do we start, and why do we start with this drug and not that drug? Where does PRRT fit in? So my PRRT slides, which are only 3 or 4, I think we can go through those fairly quickly because those were covered by Tuba. And then a little bit about sort of drug therapy coming up, genomic testing, if there are questions about that, and then lastly just an introduction to the Mayo team. So the epidemiology is that this changing. So let me explain these numbers to you. So the incidence, meaning the number of new cases per 100,000 persons per year, is now 7, and 3, like half of them are GI net, so of the intestinal tract. So if you calculate that, it would be around 400 cases in Minnesota per year. Keep in mind that a lot of these tumors are small, like rectal neuroendocrine tumors or stomach neuroendocrine tumors that never are just removed with an endoscopy and never become much of an issue other than just having to do repeat endoscopies. These are people who never will need any drug therapy and never will need any PRRT. So those numbers are in there as well. And so the median age at the diagnosis is about 63. So this is younger, maybe a decade younger than some other cancers like colon cancer and pancreatic cancer. And this graph here, let me just explain it a little bit. So the top bluish line here is just a number of new cases of all cancers from 1973 to 2012. And this obviously, the orange one is the neuroendocrine tumors. These are obviously on a very, very different scale. And so if you see there was an slow increase in cancers in general in the 70s and 80s and sort of peaked in the early 90s. And then after that, the number of new cases has actually started coming down. And I think some of it is that we're doing more coloscopies, we're catching patients with polyps before they turn into colon cancers, and then people are smoking less, and we're getting less lung cancer. So there's a lot of reasons for it. And if you look, and then obviously people are more active in screening for cancers, and we're now starting to vaccinate against certain cancers, which will possibly not necessarily eliminate cancers like cervical cancers, but could come close to doing that. And then during the same time, we see that the neuroendocrine tumor cases have actually gone up quite a bit. And this is the incidence of neuroendocrine tumors. So it's about 7-fold increase since the early 70s. And that some of this is real, some of this is almost like artifactual. So these are tumors that were not maybe diagnosed 10, 15, 20 years ago. We didn't have these fancy scans, we called them something else, and now we're actually calling them accurately neuroendocrine tumors every time, or most of the time. So they were maybe mislabeled as something else. But what we have seen, and they've not shown this year, those are data that we just generated at Mayo recently and haven't published yet, is that we've seen about 4-fold real increase, seems like in the diagnoses of pancreatic neuroendocrine tumors in the last 10 years. And interestingly, almost all of that is in patients with localized pancreatic neuroendocrine tumors, and almost all of them probably were patients were having CT scans for whatever reason. They were having a kidney stone or something, abdominal pain or something, that had a CT scan and just picked it up. Because the scans are getting better, scans for kidney stones are getting better, and we're picking up other stuff. So as you know, you can hardly walk by an emergency room anymore without getting a CT. And so with all of these CTs, we're just picking up a lot of stuff. So what I wanted to highlight here with long survival and high prevalence is that this is actually not, it's actually, as one of my colleagues who does a lot of epidemiology work said, he said neuroendocrine tumors are at the risk of losing their rare disease status, which I don't think is necessarily a bad thing. So that means possibly more funding, and because they are fairly common, they're diagnosed more frequently, patients are living much longer with them, so the number of patients living with neuroendocrine tumors keeps going up. And because we add more to the pool of new patients than patients die from neuroendocrine tumors, so there is just a lot of people out there. So this is, and I just wanted to show this, this is really across all of the different types of neuroendocrine tumors, with the most notable increase in lung neuroendocrine tumors. And then if you look at these gray circles here, these are the pancreatic neuroendocrine tumors, and they have really gone up. And I think that's all because of imaging, and they were mostly because we're just doing so much imaging. So any questions on the numbers of new? Yeah.
Can you tell me what's the youngest diagnosed with neuroendocrine?
So I don't see anyone younger than 18. So I've seen a number of people in their I think the youngest I've seen myself is 16. The University of Iowa, where I used to be for many years, they have probably the largest experience with children with neuroendocrine tumors. Is very rare, but it still happens. And so we have a lot of people in their 20s, a lot of appendiceal neuroendocrine tumors, which sometimes never become an issue. If you look at all appendixes removed in kids, you can find a neuroendocrine tumor in about 2 to 3 in every 1,000 appendixes removed. You may find a small neuroendocrine tumor.
Because with it being familial, again, our family,
yeah,
familial, I was told that my children have a 50-50 chance.
Well, it depends on what kind of a neuroendocrine tumor. If it is an MEN1 associated neuroendocrine tumor with multiple endocrine neoplasia of type 1, then the risk is really high. If it is a small bowel neuroendocrine tumor that runs in families, we really don't know the risk. That's why, and this is actually important if anyone has a sibling or a parent with a neuroendocrine tumor. And so I may have approached some of you here. So the University of Iowa has a study that we're trying to get samples from siblings or a parent and an offspring with a neuroendocrine tumor, get samples from both and doing genetic testing on it. So that's perfect. So that's Dr. Jim Howe in Iowa is leading that study. I really encourage people to participate in it. It's a little tricky to get in. It's fairly simple. You send him an email and he will send the kits to you. And you can go through me. I work with him all the time. So, any other questions on sort of the new? We'll just move into the diagnostics. So it really, as Tupa said, it's a team effort, and the key, as far as I'm concerned, is really the pathology. So I do occasionally see patients who have symptoms concerning for neuroendocrine tumors, but I try not to, because I think they are better seen by gastroenterology or for someone who's actually very used to making the diagnosis. I'm really more trained in treating the patients once they have a diagnosis. And the pathological diagnosis is tricky. A lot of people get this wrong. So there are a lot of subtle nuances with when you look at these biopsies, and a lot of times patients come in with a diagnosis of something, of a poorly differentiated aggressive neuroendocrine tumor. We change it to a well differentiated, and all of a sudden we've changed sort of the prognosis just by reclassifying the diagnosis. And then occasionally, and this happens to the best of us, occasionally someone comes in with a diagnosis of like pancreatic cancer or colon cancer, and we call it a neuroendocrine tumor. And even the other way around, it has been called a neuroendocrine tumor, and we call it cancer, like more aggressive cancer. So it goes sort of all directions. So it's incredibly important that the pathologist who looks at the slides has experience. And because that's what we base all of our treatment on. And then in terms of diagnostic radiology, nuclear medicine, there's no way we could do the work we do if we didn't have people like Tuba. And all these new scans. I wanted to put a plug-in for a new scan, which not everyone needs, but we're starting to use very selectively. And you may have spoken about it. It's a gallium-68 PET MRI, and mostly for upper abdominal neuroendocrine tumors, pancreatic, duodenal neuroendocrine tumors. Those are by far the best imaging studies I've ever seen for neuroendocrine tumors, but they're not appropriate for all patients. So they are, for example, a lot of times they miss stuff in the lower abdomen. And so if you're looking at pancreatic neuroendocrine tumors, sometimes it can be incredibly helpful. So then we have gastroenterology. There's no way we could do this without gastroenterology. Those are the people who get there's the biopsies, clinical chemistry is the people who run the markers and all this stuff, and then pulmonary medicine for the lung neuroendocrine tumors, which are actually pretty common. And I wanted to spend a little bit of time on markers. They can be helpful. And what I have found in my 15 plus years of neuroendocrine tumor work is that every year I become a little bit more of a skeptic of markers. So I used to think very highly of tumor markers in neuroendocrine tumors, and now I don't as much. So they are never sufficient to make a diagnosis. Just one piece of the puzzle, and they can help. Sometimes they can help you determine how often to do a scan. And but you have to sort of show that the marker is valuable for any given patient. So you have to follow people sort of over time, do the markers, look at the scan to see if there's a correlation. Sometimes the scan is doing this and the marker is doing that, and then you know that the marker is completely useless. And we see that actually quite frequently. We are going to be running a marker study at Mayo soon with chromogranin. It's actually a very neatly designed study from a company that makes equipment to measure chromogranin. So, just for full disclosure. And
so on the markers, my oncologist in Minneapolis says we do chromogranin all the time, and it seems like we're very, I'm also working with Dr. Alberts at Mayo, but she's very much leans on the markers. So do you share that information with other oncologists?
Yeah, absolutely. And that there may be a person where the marker just performs beautifully. And I have patients where the marker is always like spot on. And I know when the marker is going up. I can say with almost 100% certainty that the next scan is going to show progression. But there are some other, and so it may, in your case, may be that your oncologist has sort of now observed that the scans and the markers go hand in hand. And I measure, Rachel, we measure chromogranin all the time. And we're just trying for each and every patient to find out, is this a valuable information? There are some patients where it just truly isn't. The markers, the chromogranin is just all over the map.
And how often is the urine test? How often?
Oh yeah, so the urine test, I'd like to say never. So I have not ordered a urine test for 2 years. And we've switched over to plasma 5-HIA, which is a blood test that requires an 8-hour fast. And the problem with it is that we are not set up to do it at Mayo yet, so I have to send it to California, to a lab called ISI. And we have really no connection to that lab other than they just have a technology that allows us to measure 5-HIA in blood. Only 8-hour fast, no more jug, and it's now been by 3 independent groups been shown to be almost identical to the urine test in terms of utility. So and you almost never need, but the downside of it is it takes about 3 to 6 weeks to get the results back, which is really annoying. It's a very small lab. It's actually like a 10-person operation in California. But they do a really good job, and I just think it's much more convenient for the patient. Plus, that it's not nearly as sensitive to dietary intake. All you do is just fast 8 hours.
Is it respectful to ask the doctor to? Because I just got my jug on Thursday, and before I have to do. Is it okay as a patient to ask?
Of course,
that, or is
absolutely.
That
it's always okay for you to ask. Always.
So if I'll mention it to her.
Yeah. So I would just ask. Yeah, but he may never have heard of it, and that's fine. And then they may have to order in the right tubes for it. I think the ISI uses the same tubes as they do for pancreastatin. And and it's the way they collect it. They separate the blood from the blood cells from the liquid part right away and freeze it right away. So the lab just needs to know what they're doing. The ISI website actually has all of the instructions. So sometimes I just print that and give it to the patients. This is the way they should collect it. And hopefully we're talking to the lab at Mayo to see if we could set this up there. It would be nice if we could have a faster turnaround time.
Can loratadine affect CGA results? Do you know?
That is a good question. I I'm not sure, to be
Not
honest.
sure either.
No, I would have to look that up, to be honest.
Yeah.
And so there's a lot of drugs that do. So like the acid-lowering drugs, omeprazole, Prilosec, Protonix, and Nexium, and then to a lesser extent like Zantac and those kinds of drugs, Pepcid. And then a lot of other conditions like renal insufficiency. If someone has high creatinine or low renal function or kidney function, then that can elevate it. And then a surprisingly common condition which is called chronic autoimmune inflammation of the stomach, which has nothing to do with cancer, although it can eventually lead to stomach cancer, very, very common. That can actually really increase the chromogranin. So that's why the chromogranin is not a good marker, but it's still the best, fastest, most convenient we have.
I have a question.
Yeah.
I, diagnosed 28 years ago with it, and I haven't done the urine collection for 15 years, and I've been down to Iowa City, and I have an oncologist up here, so
Yeah.
I'm curious, but I've never been told to fast.
For the
So
urine,
am I not like?
yeah. So that's actually.
So what are they? Yeah.
So for the urine collection, for those of us who've done it, so you know that you have to adhere to a really strict diet. There are certain things you can't have, a lot
Right.
of good things you can't
Right.
have. And for the chromogram to reliably get a good reading, especially do with fasting. So chromogram and the plasma 5-HI pancreastatin are probably best done fasting. There's a little bit of variability if you do it like in a non-fasting state. It can fluctuate a little bit.
Okay.
So I try to do it fast, always do it fasting. There's one of our team members, Dr. Halfday, who some of you may have met. He measures markers less frequently than I do, and his outcomes in terms of treatment responses are every bit as good as mine, and he's just much more comfortable with using the scans and not the markers. So for me, the markers are just another little piece of data, and but I almost never make any changes based on the marker results. So let's move. So I think they are overused in the sense a lot of people order too many markers and order them too frequently, and just there's if you are always ordering markers, there's just a lot of noise, and you don't know how necessarily to interpret. So the ideal tumor marker should be like reliable. It should pick up the stuff that it is meant to pick up, and should not be elevated in other disease states. It should help predicting the prognosis and how effective the treatment is, and so on and so forth. So it should be clinically useful, and that marker does not exist yet. So there are some promising markers out there that some of you may have heard of, like the MET test and others, but they all have their weaknesses and strengths. So we're still waiting to get a good marker. So why do we need medical oncologist? Why do I need to be involved in this? Well, for patients like this one, so this is a patient who came in with minimal symptoms, really with no symptoms, and had a gallium scan, and you see that there's a lot of metastases, bone metastases mostly, metastases under the skin. And back when we had arterial scans or just regular CT scans, we probably would have missed most of this. And now, if his primary tumor, which wasn't even found, if there was a known primary tumor that did not have any symptoms, we would probably just leave that tumor be and not go after it surgically. So I knew right away that the surgery is not going to be helpful for this person. So does everyone need to be treated? This is a pretty interesting topic. No. So we actually observe a lot of people, and we're not the only oncologists who watch cancers without treating them. So our colleagues in hematology do this with certain leukemias and with certain lymphomas. Not everyone needs to be treated. And this is just a patient I had back when I was in Arizona. He was a gentleman from New Mexico. He was in his early 70s, very active, but lived quite a ways away from a medical center, and had these liver metastases. And one of them was proven with a biopsy. And he said, I'm just not interested in therapy. And I followed him for my 3 years there, and nothing ever happened. So I haven't looked him up since I left, but I suspect he's still doing fine. And there are just some people who have such slow-growing tumor that we can just watch them. So moving on here, and in terms of treatment, the reason we treat people, we treat obviously to relieve symptoms, carcinoid syndrome, symptoms from functional pancreatic neurotumors, symptoms from bulky, painful metastases, painful bone metastases, and then obviously we want our patients to live longer. And not all of the treatments have been shown to prolong survival, and some of them can be quite harmful even. They have side effects, and they can have unpleasant, even life-threatening side effects at times. So, and as Tuba said, that there is just not, this is not like a one-size-fits-all kind of a thing. It's all these patients are so unique. Each person is so unique that what is appropriate for one person who look on the surface, seems to have exactly the same neuroendocrine tumor as the next person. Observing one might be perfectly appropriate. Observing the other might be a bit careless to do. And so they are just so unique. And the things to consider before we start therapy, so obviously as I alluded to before, is it really needed? And then we want to know where it started. So that's why I really look hard with the gallium scans and sometimes with some molecular testing. Is it like a pancreatic neuroendocrine tumor? Is it a small bowel neuroendocrine tumor? In the microscope, they look exactly the same. And there are sometimes some ways to tease out where it started. And the reason that's important is that the treatments are so different from, if you compare the pancreatic neuroendocrine tumors, the stuff that they respond to, like the Sutent and the Captem, hardly has any activity in the small bowel neuroendocrine tumors. And then in terms of the aggressiveness, how do they look aggressive in the microscope? Do they need chemotherapy? Do they need urgent therapy? Or can we start with injections? So somatostatin analogs, as everyone knows, incredibly effective in controlling symptoms, but eventually for a lot of patients, they just stop working. So you can go up on the dose a few times, but usually at one point or another, we just can't go up any higher, and the symptoms are still problematic. So then we have other drugs like telotristat, everolimus, and some others, and PRT. And just wanted to quickly stop and talk about telotristat or Cermello. So this, as many of you know, was approved for carcinoid diarrhea in February last year, almost a year ago. And this drug does not do anything to stop the cancer from growing, nothing. Although there are some interesting thoughts in some other cancers that actually might. But for carcinoid tumors, it doesn't really slow them down, but it does slow down the diarrhea. And that's because the amino acid tryptophan, which is in a lot of food, the carcinoid tumors, they flip that into serotonin, and the serotonin causes the diarrhea, not the flushing causes the diarrhea, and that gets turned into 5-HIAA, which we can measure in the urine or in the blood. And this is a drug that, this is not the most effective drug I've used. So there are some patients who have no benefit, and then there are some others who just really seem to benefit, where the number of diarrhea goes from like 10 a day down to 5 a day, and that for a person is a major improvement. Just this year, the company that has this drug, Lexicon, they just reported on weight loss, or actually reversal of weight loss in carcinoid patients with Cermello. So patients who have diarrhea and are losing weight seem to benefit, and some of them actually start putting on weight. And then this has there's some interesting ideas how this could potentially be used to slow down the deterioration of the heart valves. So it's a useful drug. We just have to understand that it doesn't work for everyone. And if you don't have diarrhea and you don't have carcinoid syndrome, this is not really a drug for you. So as for tumor control, well, how do we keep the tumors from growing? We can use the somatostatin analogs for that. There are some. I used to have a patient, I just don't see her anymore, who had been on stable doses of sandostatin for 15 years, and with the known biopsy-proven liver and eye metastases. So we knew that the tumor was there, and she has never needed anything else. And then there are some others who only get like 6 or 8 or 10 or 12 or 14 months out of it. So huge variation. Interferon alpha we don't use much. Some of you may have had it. So we try to look for reasons not to give it, but we should not forget about it. This is a drug that has side effects, but occasionally is very appropriate. Chemotherapy for small bowel neuroendocrine tumors does not really work well. Works much better in pancreatic neuroendocrine tumors. So the Captem or capecitabine temozolomide, which many of you are familiar with, has really nice activity in pancreatic neuroendocrine tumors. For small bowel, the common carcinoid tumors, the small bowel neuroendocrine tumors, it just doesn't seem to work well. And I've tried it so many times, and I just really can't think of many patients where it really made a big impact in small bowel neurotumors. So, well, for the pancreatic neurotumors, a very sort of heterogeneous group of patients. Some people have brutal symptoms and do very well for a long time. Generally, these are more aggressive than the small bowel neurotumors. If you look at patients with pancreatic neurotumors and patients with small bowel neurotumors, those with pancreatic neurotumors have a shorter survival, but now they have a lot more options for therapy. So the survival is now the survival curves are getting much more similar now, because you just have so many options for them. And if you look at patients who are treated sort of out in the community without seeing a neurotumor specialist, they may actually have an inferior survival. And we're looking at that now. We're looking at the huge data set with tens of thousands of patients. It's a national cancer database that we're looking at. And we're actually looking at to see if we don't have the results yet. We're looking to see if high volume cancer centers have a better outcome than low volume cancer centers. And so those results, once we have them, I'll obviously share them with you. So for pancreatic neurotumors, octreotide or lanreotide is really is an appropriate initial therapy. Captem is definitely very, very effective. Sunitinib or Sutent and Afinitor have some activity. Keep in mind that the average time a pancreatic neurotumor patient gets out of Sutent or Afinitor is only about 11 to 12 months, and then it just doesn't work anymore. PRT, we all are waiting to see if it will be approved for pancreatic neurotumors. I think really it should. So I gave a talk at the North American Neurotumor Society meeting a few months ago on PRT and pancreatic neurotumors. I think I've rounded up all of the data that I could find worldwide. So, and everything seems to suggest that this is an effective therapy. So I would be incredibly disappointed if it is not approved. But then if it isn't approved for pancreatic neurotumors, we will probably have a study with a new PRT agent looking at pancreatic neurotumors. So we will, I think, hopefully get it to many of our patients. So this is just one of my patients from Arizona. So he came to me from New Mexico as well. This is a liver. So all of these bright, lighter areas are large liver metastases. He was very, very symptomatic with very uncontrolled diabetes actually, and went on Captem. And most of these tumors literally went away. And we kept him on Captem for a long time, and then he got tired of that eventually, and we switched him over to lanreotide, which I think he may still be on. So I haven't really checked since I left the practice there. So he really had a nice response to it. So it can be incredibly effective. So the PRT, I think Tuba talked about, so I'm going to skip through that quickly here. We have questions for that later. High-grade aggressive neurotumors is a very, very different beast. And they can respond very well to chemotherapy, often do not respond to injection therapy, to octreotides or lanreotide. They may or may not respond to PRT. Probably most of them don't. But then we're actually finding out that this is also a very, very mixed bag of tumors. And there are some in that group who got really aggressive chemotherapy who probably we are seeing now never needed it. Because some of them we can actually tease out that some of them may not need, if we really look carefully at the biopsies, they may not need chemotherapy for a long time. Others need chemotherapy as soon as we can get it to them. So and that's pretty much what I was explaining to you. And so here we need the pathologist. And this is even, a lot of times the pathology comes in, our pathologists read it, and like third of the time I may not be entirely satisfied with our pathologist. So I go back to the pathologist and said, can we talk about this a little bit? Can we add a couple of different tests to the tumor? And then we sort of go back and forth and try to, as a team again, the pathologist is the one who has the expertise looking at the scans, but I am the one who am actually seeing the patient. So I can provide useful information to the pathologist just as much as the pathologist can provide useful information to me. So what's on the horizon there? So briefly, we have, I don't think we're going to get anything more out of the old-fashioned sort of IV chemotherapy. I think we're into the era of targeted therapy and immunotherapy especially. And we can target blood vessels, we can target the sort of finer machinery of the tumor growth. And we can use your own immune system. So this is just to show the blood vessels. So this is a tumor. And these are the blood vessels going into the tumor. Now we have certain drugs that can almost like clamp down on the blood flow to the tumors to some extent. And Sutent would be one of them. Avastin is a drug we use for colon cancer. It may have some activity in pancreatic neuron tumors. And there are some others out there. There is a trial of a drug called pazopanib, which should be reported soon. There's another one called cabozantinib. I have no idea who names these drugs, so I don't. And so they are increasingly having longer and more difficult names to pronounce. But there are some really interesting data coming down the pike with these blood vessel active drugs, and we'll have to see where that goes. And so immunotherapy. This just to let you know, immunotherapy has not worked well yet for pancreatic or for neuroendocrine tumors. It's part of it is it just hasn't been tested well. And I've been underwhelmed with the patients I've tested. I think a part of it is that the immunotherapy we have right now is probably not the right treatment. We are still sort of in the first and second generation immunotherapy. There are some newer drugs coming down the pike. There are actually some combinations that look interesting. Even combining the blood vessel therapy and the immunotherapy may work for some patients. So I'm absolutely not writing immunotherapy off. So I think we just need to figure out who are the patients who benefit and what are the drugs we should be using. So no large studies, but some studies ongoing. And so hopefully in the next 2, 3, 4, 5 years, we'll know some more about the immunotherapy. I think for the really high-grade aggressive tumors, there may be some activity. For the lower-grade tumors, we don't know yet. So personalized therapy, so this is sort of where well, ideally this would be where we take a piece of the tumor, we do some fancy testing, we find a mutation, and we find the drug that hits that particular mutation, to give that to the patient, and it works. So we can do some gene sequencing, so we take pieces of the tumor and we can look at all the genes in the tumor, and we can sometimes pick a treatment that might work. This has not really worked well for neuron tumors, partly because they have very few mutations. And the mutations they have are not targetable with our current drugs. Most of them are mutations. You just look at it and say, yeah, hey, there's a mutation there, but then there's no drug for it. And that may all change. So I think this is definitely the future. We're going to be doing more sophisticated genetic testing, and we will have, I think, drugs for a lot of these mutations. So the problems with personalized therapy is that there is no guarantee we'll find the mutation. In neuron tumors, we don't a lot of times. And some of the mutations are just there, and we have no idea what they are. And with now, when Rachel and I are looking at the latest sort of profile of neuroendocrine testing, or genetic testing we're doing now, we have a really, really accurate and sophisticated genetic profile. We look at the entire set of genes within the tumor, and we're seeing mutations in genes I've never heard of. I have no idea what these genes do. Absolutely no idea what they do. And we can look it up, and there are no drugs, not even on the horizon, that target that gene. But as we build more, as we keep doing this and we build more knowledge, I think the drug development will follow. And let's say if we repeatedly find the same genes are abnormal, trust me, there will be drug companies interested in designing a drug for that gene. So I think this is in the future, and I think eventually we'll be doing more of the very sophisticated genetic testing and then picking the most appropriate drug. So not yet a reality for most neuron tumor patients. I can't really think of many where it really made a big difference, but we keep testing, especially if we get the tests done as a part of a research protocol as we're doing now. So I think we should keep doing this, keep gathering information, and keep learning. So I just wanted to quickly talk about alternative therapy. A lot of things out there, nothing has yet been proven to slow down or worsen or improve neuron tumors. A lot of people use something alongside with conventional therapy. I think the message here is that if patients are interested in doing that, communicate with the oncologist. Some of those alternative treatments can actually really affect the medications we're doing. We've actually seen a couple of patients who had substantial toxicities from chemotherapy at doses that should not be toxic. And then we found out they were taking a supplement that actually slowed down the metabolism of the chemotherapy. The chemotherapy just built up in the system and just sat there and caused a lot of harm. And so as long as we just know what people are doing, I'm very, very open to people trying things. And there are certain things that may help, and some of you may have heard about using papaya extract for carcinoid diarrhea. There are some patients who claim it may help, and I sometimes recommend that. It's harmless and it doesn't interact with the other treatments. So lastly, I just wanted to go quickly through the neuroendocrine tumor team at Mayo, and some of you obviously are familiar with it, others are not. And so I think patients should be treated in a team, and ideally your oncologist at home is a part of that team. So we don't want to see all of the patients all of the time giving all of the treatment, but we very much want to be a part of their treatment team. And I think that is incredibly important, that the oncologist who may see 1 or 2 neuroendocrine patients a year has access to us, who see, like Rachel and I, we may see 5 new once in a week easily. And so I think then the team members are out there, they get pulled into the team as we need them, and then if we don't need them, they just stay on the sidelines. And so it's a really big team effort. So at the first visit, so before that happens, we will review the outside documents, and we will decide on what needs to be done in terms of imaging studies, what can we set up ahead of time. We don't always know that. Sometimes we try to set up everything as best we can based on the outside documents, and then when the patient comes in, and you just think, why didn't I do that? And you won't know that the patient needs it until you sit down and you talk with him or her. And so we review the pathology. We upload all of the outside scans, and we review them and compare our scans to that. And then we get some basic laboratories, and then at the first visit we'll meet with a NET team member, and usually a member of medical oncology, can be surgery or occasionally gastroenterology or lung medicine, and then we'll review the past medical history, the treatment history and everything there, and talk about more tests if needed, and then finalize a treatment plan. And the key is that we'll communicate with your primary oncologist. And then the unique thing being at a very large institution is that we can actually take this to what's called the tumor board. So there may be, and for example, in neuroendocrine tumors, we meet every 2 weeks, and we can take the more challenging cases there, and there may be like 15, 20 people in the room who all have a lot of experience, but there may be like 100, 200 years worth of experience in that room. And sometimes I come there with what I thought was like the greatest plan, and they leave with a completely different plan. And so you have to be able to modify your plan, listen to your colleagues. So this is the core neuroendocrine team. So that's Tim Hopday and Rachel and Diane, who is the nurse on the team. So, but the Mayo team is actually a lot larger than this. This may be the actual NET team right now. So this is the Mayo Medical Oncology NET team. So these are all GI oncologists. So these people are all trained in GI oncology. And all of them are incredibly comfortable with and incredibly knowledgeable about the neuroendocrine tumors. It may just not be the most of what they do, but all of them, with each and every one of them, they truly are specialists. So we have 3 within GI oncology, 3 nurse practitioners or APRNs. So Minty, Jessica, and Akiko. And then I added in 2 of the lung cancer team members, so Erin and Anna, and they may be seeing some of the lung neuroendocrine tumor patients. And then we have our nurses who are absolutely outstanding. So these are the surgery team. You may have met some of these surgeons. So we have 6 surgeons now specialized in neuroendocrine tumor surgery, and some of them with decades and decades of experience, like David Nagorny. And then all of them are incredibly capable. The interventional radiologists, there are more of them. I just put in those who are the busiest with neuroendocrine tumor patients. The carcinoid heart disease team is, I think, the largest in the world now. So we have 3 cardiologists who specialize in that: Heidi Connolly, Patricia Pellica, and Ellen Lewis. And then Hartzell Schaff is the surgeon who does most of the operations. There's no one, and I don't think there's anyone in the world who has done more carcinoid heart operations than Dr. Schaff has. And then I added in the Mayo endocrine oncology team, because sometimes at these neuroendocrine tumor meetings there is someone who actually has a pheochromocytoma or a paraganglioma, which is a neuroendocrine tumor, and they will be managed by a different team. So they would not come to the core neuroendocrine tumor team, or generally not. I'm very comfortable treating them, but they will end up on a different team. And the lung and that team, this is really the lung cancer team. And if you have a lung neuroendocrine tumor, you may meet with any of these oncologists or any of these surgeons. So as you see, what I wanted to show here is that these are this huge team. And then we have gastroenterology and radiology and clinic assistants and scheduling people, and it's just and everyone that I didn't really mention. So apologies to those who were left out. And so I really just wanted to finish on that note. I think this is best done on a team, and your primary oncologist is or should be a part of that team. And they're obviously welcome to be a part of the team. We're trying to come up with better ways to communicate with the primary oncologist. Now it's sort of email, phone calls, and eventually some of them can actually dial into tumor board. So if they're a part of the Mayo Health, Mayo Clinic Care Network, they can actually virtually present the tumor board, and we haven't had many participate in that yet. So there are all sorts of options for them to be more active. And then obviously we, not just Mayo but others, we want to be out there and as new things happen, sort of disseminate the new information. So I think I'll stop there. So we'll have some time for questions. Maybe have Rachel come up here for some of the questions. So sorry, it was a little long presentation.
No.
Hello.
It's Rachel, for those who don't know Rachel. Okay, grill us with questions.
All right.
I have a question. So what's different about the NET clinic, right? There's the clinic opening?
Yeah, so the NET clinic is really a clinic within a clinic. Maybe I'll have you explain that.
So Dr. Thor shared all of our GI oncology team, and within that there's a smaller group of us who we really wanted to make sure we were the providers who are reviewing your records when you send it to want to come here, but then we also not only want to review your records, we want to see you. So how getting an appointment works at Mayo, you send in some records, it's reviewed by one of our providers, and we try to set up your correct appointments. We might see a different provider than who actually reviewed your records. This was an attempt to try to focus it down to those of us who are really interested in taking care of patients with neuroendocrine tumors so that we can really become experts and also then expand our resources because we know it's beneficial to have expert nursing involved. One of the things that we're really making a push on is having our dietitians take that extra step, because I think a lot of times you meet with a dietitian and you get kind of a general cancer information, and that's not really helpful for you. So can we spend more time focusing, training our dietitians to really be able to give you more resources, that sort of thing. So we're really just trying to build the expertise.
So it's probably never going to be like a clinic that has like a name on the door and this is the tumor clinic. It's always going to be a clinic within, sort of a team within a team, or a clinic within a clinic. And if you have esophageal cancer, I may not, although we are very comfortable dealing with that, you may be going to another team within the team. And so it's really just trying to get, at least just trying to build sort of more expertise and just make the team more efficient and nimble. And we always work with the same surgeons, and I think it's just, at the end of the day, makes for smoother care. And then the other thing with it is that if the community oncologists know it's a small core team, it's easier for them to say, well, to just contact the team, and instead of trying to guess who at the Mayo, and we have 50 oncologists and within our division. We're just trying to create better service, essentially.
So this is a question from somebody asked me to ask. It's just getting some more insight into what's going on in Australia with the CAP10, TEM, and PRRT study.
So something that we are intensely interested in. So we're seeing that the response rates are really high. So giving chemotherapy, CAP10 or temozolomide or capecitabine with PRRT is very effective. What we don't know if really is it more effective than CAP10 alone, which actually is really effective. So I think what needs to be done eventually is to create a clinical trial where we have a number of patients, maybe 10, 15, 20, 30, 60 patients who come in, and half of them get PRT and half of them get chemo PRRT and see if there really truly is a difference.
Okay.
So we have not used it here. It's the Australians have shown that it's safe. There was a study that just got published last week from Italy, again showing safety. So something that we will be paying a lot of attention to.
Sure.
Probably not using. I think we'll first have to learn how to really get good with the PRT before we start adding other things into the mix.
I think
Thank
it's
you.
the logistics of scheduling PRRT in a streamlined way where it's organized, and that we needed approved for to get going on.
So if and when we get this approval on January
Mhm.
28th, how long do you think before our insurance companies are willing to approve treatment? I mean, once it's FDA approved,
Yeah.
do they more or less have to?
Yeah. So based on what we've seen, let's say with the immunotherapy drugs, we've seen that approved for a lot of tumors. It seems like it happens very quickly now, and the data to support PRT are really, really strong. And I would be absolutely shocked if it does not get approved. And just looking at the data, I've never the treatment, the efficacy data, the numbers, the survival curves, just look so striking. This is such an effective therapy. So I think, and we will, trust me, we'll get after the insurance companies, and we'll really pester them with data and phone calls and letters, and I don't know in terms of the capacity of the company that makes this AAA. So if this gets approved, and all of a sudden nationwide we have like 1,000 patients who want PRT, can they cook up 1,000 doses of it in a month? And they may not be. They're building a facility in Jersey, and I think it's up and running. And there is a representative from AAA there. Any word on that?
The facility's up and running. It will be closed down temporarily to get FDA approval for GMP manufacturing after the drug is approved. So currently we're providing doses for patients on EAP from that facility as well as our Italy facility, but we just have to go through the inspection and the time frame that the FDA requires to get it up and running to have a local in the States facility.
Yeah, so when we see the patients, we sort of think, does this person need PRT like urgently, like in the first 2 months? There are some people who, let's say with pancreatic neuroendocrine tumors, who have not had Afinitor, or some with just the common carcinoma tumors have never had Afinitor, or they have like 2 liver metastases that's growing and we've never embolized them. And so some of those patients will probably try to use Afinitor and embolizations and try to prioritize the patients who really truly are in need for getting this done quickly. And I saw someone yesterday, and last week, and the person I saw, and I thought, he's going to be probably towards the top of my list. This is the one in the most need I've seen. And
And what would that look like?
so it would look like progressive disease that really lights up on scans, having progressed on all of the available treatments. So that person had been on very high doses, like sandostatin, 60 milligrams every 3 weeks, Afinitor, and was now progressing and with a lot of symptomatic metastases, bone pain, and painful lesions. And we thought, well, this is something we need to treat urgently. Then there's someone else who's had relentless progression, but maybe a liver tumor has gone from 1 inch to 1 1/3 inches in a year. That patient may still, and is probably still a good candidate for PRT, but we could wait a little, especially if that person has not had Afinitor. So we'll just have to look at, again, looking at every case individually.
This is kind of a weird question, I guess, but at how many treatments of an increased dosage of sandostatin can you make the determination if they are, I know it's a really vague question, and everyone's different, but can you say, would you notice a difference in 2 treatment cycles, or?
Sometimes you could. So, and the difference would really be that I've seen this time and again, is that someone has progressive disease and we double their sando dose, and then the next scan is the first scan in like 4 scans that didn't show progression. So keep in mind when the Netter study was done that the reference arm was actually high dose sandostatin, so 60 milligrams monthly, and on average those patients went 7.5 months.
I was gonna say, it was more effective than I expected it to be.
It actually was, yeah, I agree. I was looking at it, that's actually a thought. Well, that actually is more effective than I thought. And there have been like 2 or 3 in the last week. I doubled the Sandoz dose on just waiting for PRT.
Is it better to double the dose or shorten the interval, or does it depend?
Depends on symptoms.
Yeah, I would say it depends on symptoms. You have some patients who always notice their symptoms worse that last week of the cycle. Those are the patients I'm going to think about going to every 3 weeks, versus if it's the entire month that's bad, that's more of a dose issue.
So we wanted to go every 3 weeks, but our insurance won't allow that. Is that a common?
Very, very common, and most of the time we've been able to make like a peer-to-peer call to the insurance company, and almost, I'd say almost always, if you get a person on the other end who's reviewing the case from the insurance company, you can make a good case for why it is. And the person might say, well, this is only approved every 4 weeks, and then you tell them, well, the last week is miserable, and then they, well, most of the time I'd say, listen.
We've tried to go to the short-acting shots at home
Yeah,
for the last week. And
Sometimes do, but then if I had so many who just where the diarrhea really like picked up, or the flushing picked up in the last week, and they just shortened the cycle to every 3 weeks. It is another. It's more injections over the course of the year, but for some people it really works.
So who calls and throws their way around to insurance? My
So it's
oncologist here.
the
or somebody from Mayo?
primary oncologist usually, the one who is administering the drug. So that's the one who's dealing with the insurance company. So if you come to Mayo but you're getting all of your shots at Park Nicollet, they will have to do it. And
I think she's tried that.
yeah. And sometimes if that doesn't work, then we're obviously happy to see what we can do. The other thing, what we can do, and this is something I pay attention to, sometimes the octreotide, the sandostatin injections are not correctly given. And you can see on the CT scans that they are ending up in the fat in the buttocks and not in the muscle. And the sandostatin is not designed to be given that way. Lanreotide actually is. So for those patients where especially, and this is probably most important for a neuroendocrine tumor patient who goes to a clinic that does not treat many of them. Let's say if you're the only patient who is on such therapy and the nurse administering it, he or she is trying to do their best, and you see that all of the shots are ending up in the fat, then I say, well, why don't we just switch to lanreotide?
Which do you believe is better?
I don't think there's any difference. No, the trials were done very differently. So the sandostatin and the lanreotide trials, different populations. So although the numbers for lanreotide look a lot better, they had a much slower growing population in that study. So I don't think there's any difference.
I would say I think there's a little bit more side effects personally with lanreotide
Agree,
than
yeah.
octreotide.
More pain?
A little
Yeah.
more pain, a little bit more pancreatic insufficiency symptoms.
Yeah.
So
A lot of good questions. Keep them coming.
You mentioned in the talk that kind of when there's less tumor in the load in the liver, that the PRRT works better. Is there a point at which you're too far?
I don't think so. So this is a hotly debated topic, and there are people who really believe that Y90 PRRT is better than lutetium PRRT for that reason. The thing is that these tumors have such a network of small blood vessels, even though they are very large, they are like every tumor cell is getting blood from somewhere. And so I don't think it matters. We know that the people with large volume of disease of all cancers, they generally tend to have a more difficult disease to treat, and they get less of a response, and the responses last shorter. So I think, but then I don't think there's really any. We've all seen patients with large volumes of disease getting PRRT who had a really good response. Keep in mind the PRRT responses can occur late. I remember the first one I got from Switzerland was, this is 10 years ago in Iowa, and they came in, the first CT scan looked a little worse, and we didn't really have anything, and we said, oh, we'll just wait. And the second CT scan looked a little bit worse. We're talking like millimeters. The third CT scan looked better than the first one, and then like 3 CT scans after that, things were getting smaller. So sometimes you just have to wait a little.
That on some of the after PRRT, that tumor can actually look larger because it's dying from the inside.
It can.
Yeah.
And then everything on gallium scan looks larger. So like I tell people, looking at the gallium scan, you see all of these things. It's like looking at a bright light bulb. So all you see is this big halo of light, and then you turn the bulb off, and it's just like a tiny little bulb. And so there's this huge halo of activity sometimes. So we put those like scans up and look horrible. But if you look at the actual tumors, the tumors are actually sometimes fairly small. They just light up so bright.
Okay.
Are there ever false positives?
Yes, of the scans. We've actually, now as Tuba said, we've done 300 scans. We've picked up 1 prostate cancer, we picked up a lymphoma, and we picked up a lot of benign stuff. So inflammatory things, and so there are definitely false positives.
That can be hard sometime when you're chasing markers and getting something that lights up a little bit on a dotatate, but isn't convincing to know what do you do with that.
And then one part of the pancreas, like called the unsettled process, always lights up. And then Dr. Hopp, they picked up a benign fibroid of the uterus in someone, which I didn't even know of, that could light up.
The liver and the bladder always light up on the gallium scan.
So the spleen and bladder.
How do we determine though if there's activity in the liver or the bladder?
So that's a great question. So that can be, so for the bladder, it's a rare site of a neuroendocrine tumor. If we think there is something there, we do a cystoscopy, take a look up there. With the spleen, which always lights up, if we think there's something there, then like an MRI of the spleen is, that's I think where in those rare cases, I think that's where the PET MRI really shines.
And would you do that for the liver as well?
The liver has a little bit of uptake, but usually if you have neuroendocrine tumors in the liver, they'll have more uptake than the background liver, so you can still see liver lesions fairly well on a dotatate.
With Ki-67, should you get that checked more than like once?
That's a good
I think as a rule, if the tumor starts behaving differently than it has been, you better think about a repeat biopsy to see how that has changed, because that might be the situation for a small bowel neuroendocrine tumor, and now there's a high Ki-67 where you maybe would think more about some of those chemotherapy options or pancreatic neuroendocrine tumor options. So if it's not behaving how you think it should, get more information.
I agree. I have nothing to add to that.
Very last technical question, just talking about pain afterwards, the embolization last summer, and which is very painful due to scar tissue, they were saying that is some of the cause of it. I think Rachel, it was you that was talking with us, but so I'm wondering as it starts to die from PRRT, is that going to be the same type of abdominal pain?
That is a good question. So I don't think we fully know.
I know the few patients who I took care of on the NETTER trial who got active treatment did have some abdominal discomfort for a week or so after their treatment, but I haven't seen any long-term pain from it.
So the third patient on the expanded access protocol we had, she's a young woman from Texas. She had on the third week, she was actually admitted there with a severe sort of upper abdominal pain. And we thought could be from inflammation from dying tumor cells. And then when she came back, all the flushing was gone. And the pain, we didn't do a scan yet. It's not time to do a scan yet, but the markers were down. So I've been thinking with that person, were we seeing inflammation? Possibly. So, because it was all like over the liver where the tumors were.
So I'm 1 week in. So I was just there, I'm in that expanded.
Access protocol?
I was there in December and coming back in February. So the third time around is the time when it's going to really hurt?
No. So it seems like if anything, it seems to be less. It seems to be most the first time. And but this is something that we have to sort of collect this information. Because keep in mind that although we have a lot of experience taking care of patients who've had PRRT, we don't have a ton of experience giving it. No one has in the U.S. except Excel Diagnostics in Houston. They've been doing this for years, and University of Iowa. And Most of the others we treated like a handful on the netter, but now we have 10 patients on the expanded protocol. So we're actually getting a lot more familiar with it now. Any other questions? Okay, one back there.
Talk of some type of research grant where they're administering IVs of vitamin C for GRT.
So I'm not aware of a study, but there's a lot of IV vitamin C studies being discussed now, and there actually may be a marker that, like a tissue marker that may predict who will possibly respond to IV vitamin C. So one of our fellows is actually working on that.
It was part of the prior to GRT that we give vitamin C.
Yeah. We are actually going to be looking at the pancreatic nerve tumors at Mayo, and we're going to be testing a handful of them for that the test that may predict activity of vitamin C. So when I was at the University of Iowa, we participated in a study that looked at very, very high doses of vitamin C in pancreatic cancer, not in neuroendocrine tumors. And all we were testing is really to see if it was safe to give it with chemotherapy. So I don't think I would keep an eye on vitamin C. There may be a role in cancer medicine. I just don't know what that role will be.
After you've had the PRR treatment, is there a certain length of time before you would start seeing growth again, an average?
Yeah, we're waiting for, that's a great question. So how long on average will you go? And with the netter study, the study that was done, when they reported it, less than half of the patients had tumor progression. So we don't really know what that magic number is going to be. But we know from Europe it's probably going to be somewhere between 3 and 4 years for most patients. Or like the average. Some can go much more than that, others don't get anything out of it. And then we just learned last year as well that from the group in the Netherlands, you can actually repeat it once or like do a full set of 4s 4 or 5 years later, and then do a half a set beyond that.
I know that.
Yeah. So we're all very excited to see those results. They've only been presented at meetings. We haven't seen sort of the full report.
It's been 4 years for me, so.
Yeah. So there are some who get a long time out of it.
So here's kind of a loaded question. If there's one thing that you could do to enhance Mayo's recognition as a center of excellence for NETs, what would it be?
Oh man. So I think I don't know. I think what we just need to. I think we just need to get the word out, and we're not, that because these are rare tumors, and the average oncologist may have a handful of patients. We have literally we're actively treating hundreds and hundreds of patients. I think we just need to let neuroendocrine tumor patients know and oncology providers know that we are out there, not just Mayo, they're all Iowa, all of these other specialized centers. And what I envision is really that every neuroendocrine tumor patient in the country is linked to a center. And my goal, and where actually I'm a part of the education committees at the NANET, where we're actually addressing this and training neuroendocrine providers now. So we have this show that goes around the country, and we give like a full day courses on neuroendocrine tumor management, and because we want to have experts in every state.
Good. Well, like you said, you see maybe 5 new NET patients a week, perhaps.
At least.
And I'm on a lot of the boards, the Facebook groups, and of course every day you hear new people, right, who have just found out, and of course they're freaked out, and consistently everyone tells them see a specialist.
Yep.
Because there's too many bad examples of things that have gone wrong.
Yep. And then probably the most important thing, one of them is sort of when they come to us, when we have a discussion with the surgeons, who should have surgery and why should we do surgery now or why should we not do surgery now?
And the pathology review, having an expert pathologist look at the tissue to make sure the diagnosis is correct. That's huge.
And that actually happened at Mayo. So we did a biopsy, which we read as a neuroendocrine tumor, but just because we set things up so that it's sort of overread by the really sort of unclear cases are overread by another pathologist, who may not have knowledge of the case.
Yes.
So the first pathologist, who's actually one of our best ones, he called something probably neuroendocrine tumor, and the next pathologist said it's not. And then they looked to brought the third one in, and then they decided that this is not. So even the best pathologists out there get it wrong. Interestingly, probably one of the best neuroendocrine pathology program is in New York at Memorial, and they have 3 neuroendocrine pathologists who are looking at high-grade neuroendocrine cases, and they took like hundreds of them. They individually read them all, and then they compared the notes. Third of the time they disagreed. And these are the best in the country.
Right.
So that's why, and if you see a Mayo pathology report, you will see a pathologist who signs it, and then below it says, seen in consultation with Dr. So-and-so, and maybe 2 or 3 others.
Regarding marker testing, if you go from lab to lab to lab, the results can vary, I guess. Not really a good thing to do. Would you say the same is true of gallium scan from facility to facility, or a MRI or CT, both, the equipment as well as who's reading it?
Yeah. So here, so we don't know, well, I think we'll see with the gallium scans, because they are now getting more common.
Yeah.
And I think, but here, by far the biggest difference is in CTs.
Okay.
So you can have, everyone has a really good CT scanner. Not everyone knows how to use it.
Mm-hmm.
And the simple things, the most common mistake by far is the wrong timing of the contrast injection. So you can have people who both have like a CT scanner that costs $500,000. I don't know what it costs, and the best top of the line CT scanner, but one of them, the contrast timing is off. It happens all the time. And then you do a CT scan. Some of you may have seen that. Sometimes you can have an outside CT that shows nothing, and then you got the CT at an institution that has very, very high volume of liver imaging, where the contrast timing is like spot on, and everything lights up. And that's more just a training issue of the technologists.
Sure.
I think part of it too is when you're looking for a neuroendocrine tumor, we often will do biphasic liver imaging, so arterial and portal phase imaging.
Oh, okay.
If you come in, get a CT in an emergency department, and it's kind of an incidental finding, but they didn't do that, both of those phases, you might not see it well.
Sure.
And then you come to us and we know what we're looking for and do 2 phases.
Yeah, so sometimes you have to give them some credit for the scans. If you came in with abdominal pain, they do the best, quickest scan to find out the things that are, is this something that's like life-threatening, and they do sort of a standard CT scan.
Sure.
That's not an ideal scan, and we will do the same in our emergency room. And then and that's why it's so important that we review the documents before you come in, so we can decide on how to do the scans.
Very good, thank you.
Okay. Well, thank you very much.
Thank you.
Hey, thank you.
What was Rachel's last name?
Eiring. Eiring, E-I-R-I-N-G.